I want to introduce our first speaker, who is Dr. John Casey. John is a fellow of this college. He's a consultant transplant surgeon at the Royal Infirmary of Edinburgh and honorary reader at the University of Edinburgh. He's lead clinician for organ transplantation in Scotland. He's also chair of the UK Islet Steering Group and advisor to the Scottish Government on organ transplantation. He has been heavily involved in the new legislation. So I'd like to introduce John.
Thank you, Richard, and thank you to the college for asking me to speak at this webinar today. What I'd like to do is talk about some of the reasons behind moving towards an opt-out system and what we hope to gain from that, and then to speak about some of the discussions that are needed in discussing organ donation. So, as you said, the law is changing from this Friday, and it's been a long process of development over the last few years. And it's one of the really important things that we should take away from this today is that we do need to talk, and as Jackie said, that both in our personal lives around the decisions around organ donation, and also in our professional lives going forward. Now, looking at the reasons behind moving towards an opt-out legislation, we have actually done very well over the last 10 years in the UK in both increasing the number of donors and also increasing the number of transplants. And you can see from these NHS blood and transplant data that we're in almost what would have been an unimaginable situation 10 years ago, with over 1,500 donors in the UK and at one point peaking over 4,000 transplants. So over a 50% increase in the number of donors and almost 40% increase in the number of transplants. However, there are some subtleties to these data. Most of the increase in the number of donors that we see are from DCD donors, and we know that the number of organs that we can transplant from these donors is fewer than DBD. But also, if you look more globally, we still have a relatively low DBD organ donor rate compared to other parts of the world. If you look at Scotland, then our progress in Scotland very much maps what's happened in the rest of the UK, with a 50% increase in the number of donors and a significant increase in the number of transplants and reduction in patients on the transplant waiting list. And this achievement is due to a whole host of different factors that have been put in place over the last 10 years, including the 2008 task force organ donation, and also taking organ transplantation to 2020. But also very locally in Scotland, an organ donation and transplant plan for Scotland was instituted in 2013 to put into place infrastructure in the UK, which would increase the number of donors that we have and increase the progression of these donors to organs that we can transplant. The focus that we have now is on increasing consent, or in Scotland, the authorization rate. Now, if we look at these data from the potential donor audit that is taking place in the UK, we can see that particularly in DBD donors, the referral rate for donors from the intensive care units is very close to 100%. So there's very little that we can do to increase that. But what we can see is that the consent rate, or authorization rate, for donation remains around 50 to 60%. And it's this area that we feel that the new legislation may help us increase going forward. As you've heard already, the legislation changed in Wales in 2015, and it did take a few years for us to see an effect. But you can see from these data that the change in the law has made a significant, both clinically significant difference in Wales, but also statistically significant difference. In England last year, Max and Keiras Law was introduced after a media campaign based around a young lad, Max Johnson, who received a heart transplant from a young donor, Keira. And this was a very emotional time, and clearly this has made a huge difference to the attitude to opt-out legislation. Clearly, it's too early yet to know whether or not the legislation has made a difference in England, particularly in light of the COVID outbreak. Now, in Scotland, particularly, why are we moving to an opt-out system? Well, looking at the public consultation process that took place in 2016, almost 90% of the Scottish population support organ donation. However, only around 50% are actually registered on the organ donor register. Now, I say only 50%. That's still a high rate, especially compared to other parts of the UK. But when we realise that only 1% of patients who die in hospital can become a donor, and also that at any one time in Scotland we have around 500 patients waiting on the transplant list, and we feel that there's more that could be done to increase donation. And it's also very important to realise that around 50 patients per year in Scotland die while waiting for an organ transplant. And so the Human Tissue Authorization Act authorization bill was passed in 2019, and this is a very austere looking piece of legislation that we see here, but it's hugely significant and marks a huge turning point in organ donation and transplantation in Scotland. Since the bill was passed, there's been a great deal of activity within Scottish Government and in the advisory groups that I'm involved in, and other groups, to take it from a bill and a piece of legislation to a practical process, and taking along the public and other professionals along with us to ensure that there is confidence in the bill process and in what the law now contains. So, how does the opt-out system work? Well, first of all, there is choice. Despite the fact that there's an opt-out, this is what would be termed a soft opt-out system. And it's very important, and I go back to the point that I made at the start, that talking and conversations are extremely important. So everyone has a choice whether they wish to be a donor or not, but it's very important that we, as in our personal lives, consider organ donation, make a decision, and discuss this with our families. So there's a choice made. When a patient dies in circumstances where they maybe become an organ donor, there are checks made to ensure that the will of and the intentions of that patient are carried out. We also ensure that there are protected groups, such as those under 16, those who are not normally resident in Scotland, and those who are incapable of understanding the legislations as it stands, to make sure that these individuals are protected by the law. And there are also some additional tests that are sometimes required, which are now part of the legislation. So the law, the main aspects of the Act really fall into three areas. First of all, a duty to inquire about the intentions and the will of the potential donor, to decide on whether authorization is express, deemed, or has to be a nearest relative authorization. And also it protects children and has specific aspects around authorization in children. There are some pre-death procedures which are normal practice for patients who are potential DCD donors, and the law now takes a consideration of these pre-death procedures and classifies them into type A and type B, and I'll come back to discuss those in a few minutes. There's also a duty to update the law, reflecting current practice, and also duties around awareness raising. The way this fits into the whole donation process is outlined here. Fundamental to this is ongoing care of the patient, particularly as in DCD patients. There's also the duty to inquire, which I'll come back to, which must precede the undertaking of any pre-death procedures for DCD donors, and the process that you see which ultimately results in the authorization for organ donation. So the summary around how authorization is achieved is quite well illustrated here. Central to this is the duty to inquire. This ensures that the last known decision of the potential donor is explored, and that evidence and information and the views of the individual are considered to establish whether or not donation is authorized. If we look to the left of this slide, it outlines situations in where donation can be authorized. And this is where the donor has opted in by a decision prior to death. And the clear example of this is by registering as an organ donor. And this is express authorization. The potential donor may have an opt-out decision in place, but may have newer evidence of willingness to be considered as a donor, and this is where the duty to inquire would elicit this willingness. Authorization can be deemed when there have been no views about not wanting to donate, and there may also have been verbal views supporting donation. And in protected groups, and there would be nearest relative authorization. There may be circumstances where donation would not be authorized, and this would be if the patient has opted out prior to death, again on the organ donor register, or indeed if they have opted in, but there's newer evidence of unwillingness to proceed as a donor. It may well be that there have been verbal expressions by the patient prior to death about not wanting to donate, and therefore authorization would not be given. And also there is the potential for nearest relative override. There are situations where the law, the deemed authorization law, does not cover, and this would be in what we term accepted body parts. It's termed in other parts of the UK in different ways. In Wales, it's termed excluded relevant material, and in England, novel or rare transplants in circumstances which would exclude face, whole limb, hand, etc. But it's quite important to realise that that tissue donation, such as tendons and skin, can still be deemed. There can be authorization taken for purposes other than transplantation still, and this would include research, education and training, and audit. I mentioned the situation of pre-death procedures, which refers to DCD donors, and these have been classified after a great deal of consideration by clinical groups into type A procedures, which are procedures that would be part of normal practice, such as urine samples, standard blood samples, and these can be considered as deemed within the legislation. But there are other procedures that we have considered type B procedures, which may include procedures such as bronchoscopy, CT scanning, MRI scanning, and so on, which would require authorization from nearest relatives to take place. So, in summary, we have to remember the law is changing on Friday, and there are three clear areas that we have to think about, and these are well described and illustrated in the Organ Donation Scotland website. We have to make our decision, register our decision, and share our decision. Thank you for listening.
Thank you very much, John, for that clear explanation. I was saying that if you want to pose a question, could you please put it in the chat box, which you'll find on the right of your screen, and perhaps I could start some questions. John, you didn't mention if an adult lacks competency and what the safeguards there were.
So there are safeguards within the law for adults who are deemed incompetent or to understand the legislation, and nearest relative authorization would be taken in those circumstances.
Okay, thank you. And what do you think? The Welsh situation was linked with an education programme, and that seemed to be very effective, and in fact their increased rates of consent started before the law changed. What do you feel about education programmes? And perhaps you could divide that into two: firstly for professionals and secondly for the public.
Well, I think over the last 10 years, there has been a greater emphasis on public education and information about organ donation, and we have seen a significant increase in, as I showed earlier on, the number of donors in Scotland and in the rest of the UK, and in the consent rate. So I think these processes do have to continue and should continue, and I think it raises the very important point that the new legislation is part of all of this process. It's not the one aspect that will necessarily change things around, but it is part of an ongoing process. Also, professional education, the part of the restructuring of organ donation in the UK has been around the appointment of specialist nurses for organ donation, but also clinical leads for organ donation in the intensive care units in the UK. And part of their job is to educate professionals and intensive care professionals in organ donation and keep them up to date with this. So I think all of this is really critical, that we keep going with all of these processes.